All right, everyone. Welcome to week 2 of psychopharmacology. Today we have a very big topic. Actually, we're going to be talking about mood disorders, which is pretty big. So that encompasses mood disorders, are major depressive disorder, bipolar type 1 and bipolar type 2, psychothymia, and persistent depressive disorder. All right. So I'm not going to cover everything in detail, obviously, but we'll leave some questions and answers at the end if things weren't clear in your reading, and we'll discuss it deeper if we have to. Okay. All right, so once again, I'm just going to do a quick review of what we did last week, just in case you missed it. Remember, this is a neuron. The exchange of the genetic material from the first presynaptic neuron to the postsynaptic second neuron is really where the magic happens. So remember, the axon potential has to travel down through the axon, and then it ends at the axon terminal, and that's where the neurotransmitters are going to be released to the second postsynaptic neuron. All right. This is just a close-up of it again. So notice that we have receptors on the postsynaptic neuron. There's also receptors in the presynaptic neuron, which sometimes we call those autoreceptors. And we're going to discuss that in detail a little bit later on. We'll discuss how the SSRIs and other antidepressants work. All right. So how neurotransmitters are sometimes degraded is two things. Number one, they can be reuptaked again. Remember, they're recycled, especially serotonin, norepinephrine, and dopamine, so we don't waste energy. And they could be degraded, all right? So usually they're degraded by enzymes. So you have an enzyme that we use sometimes for treatment called monoamine oxidase inhibitors, which is usually outside of the neuron. Inside of the neuron, and you have something called COMT, which is catechol O-methyltransferase, which is outside the neuron, all right? Those are enzymes that break down the neurotransmitters, just so that you don't overstimulate that postsynaptic neuron, right? Because sometimes excitotoxicity can be dangerous also, all right? Once again, types of neurotransmission, anterograde, which is considered classical neurotransmission, that's moving from a presynaptic neuron to a postsynaptic neuron. Retrograde neurotransmission is when the postsynaptic neuron actually translates back to the presynaptic neuron, right? And the three examples that I've given you guys were nitric oxide was one, endocannabinoids were two, and then neural growth factors were number three. Okay. Volume neurotransmission happens a lot in the dorsolateral prefrontal cortex, and specifically with dopamine. So that means that when a presynaptic neuron spits out dopamine, right, because we don't have a lot of dopamine transport reuptake pumps actually in the frontal lobe, it's going to cause something called volume neurotransmission, kind of like a puff of smoke, right? It's going to disperse out, and the presynaptic neuron can actually communicate to other neurons that are very far away. Okay. These are the targets of psychotropic drugs. So you realize, if you guys noticed that, it was more basic last week, but I added some more details for this week because we're going to discuss, the receptors. I know some of you guys had questions about that last time. So remember, 12 transmembrane region transporters, that just means that the protein goes in and out of the membrane 12 times. That's why they call it 12 transmembrane. And an example of that would be the reuptake pumps, all right? So you have SSRI, which is selective serotonin reuptake inhibitor. You have SNRIs, which stands for serotonin norepinephrine reuptake inhibitor, and you have DNRI, which is actually dopamine norepinephrine reuptake inhibitors. All right. Any questions? No. Okay. G protein link question?
Yeah. On the targets of the psychotropic drugs. So yesterday I was reading like the chapter 3, the Ettinger.
Okay.
Are we going to be expected to remember like the 5-HT2A? Like,
of course, yeah, you have to. That's very important, actually. Yes, it is. That's why I'm putting it there.
All right. No, okay, I remember that, but just like we know the 5-HT, you want us to remember the 2As, the 2Cs.
Of course, exactly. Okay. You have to. That's the way we're going to prescribe meds effectively to our patients. All right. So remember, 5-HT is just a simpler way of saying serotonin. So whenever you see 5-HT, it just means serotonin, right? So 5-HT2A would be serotonin 2A, 5-HT2C obviously serotonin 2C, and so forth. Okay. I just listed a few here, but there's actually a little bit more. The serotonin family of transmitters or receptors are actually pretty complicated, but I'm going to touch on it in a basic way, but we can go into detail if you want. All right. G protein link receptors, once again, that utilize the second messenger proteins, right, with the cascade. Those are the D2 receptors, dopamine receptors, 5-HT2A, serotonin 2A, 5-HT2C, 5-HT1A, and then 5-HT7. These receptors I put because these are receptors that are important in mood disorders, all right? But there's other receptors that are important in other disorders as well, like anxiety. Enzymes, MAO inhibitor, remember, you want to keep as much neurotransmitter in that synaptic cleft as possible. So one way you can do it is by actually stopping the mechanism of breaking it down, right? So giving someone a medication that's an MAO, monoamine oxidase inhibitor, can actually increase or keep whatever's there is there, okay? So that would actually affect all three: serotonin, norepinephrine, and dopamine, right? Which is considered monoamines. Ligand-gated ion channels, okay? So an example of that would be 5-HT3 NMDA receptors, all right? So we have meds that are NMDA antagonists that actually work on that receptor that helps with depression. And we have GABA-A neurosteroid site, which is actually a site that doesn't work with benzodiazepines. So we're going to talk a little bit about that as well, okay? Voltage-gated ion channels are, the voltage-sensitive sodium channels, and voltage-sensitive calcium channels, and so forth. And those would be the anticonvulsants and mood stabilizers. A lot of material. Any questions so far? Did I lose anybody? Please slow me down if I am. Anything needs to be repeated or clarified? No. Okay. So once again, just to review this concept, which is going to be very important, upregulation and downregulation. Remember, it's compensation for what you're doing artificially to the brain. All right. So you give someone a dopamine blocker, what's going to happen? You're blocking those receptors. The receptors are not used to that blockade. They're going to upregulate, right? The receptors are going to go up. And also at the same time, it might be more sensitive. So that would be called sensitization. It becomes very sensitive, and new receptors are going to get put on that postsynaptic neuron, and it's going to upregulate. Okay. The opposite. You're taking a substance, you're taking a medication that's always stimulating your receptor, right? In order to prevent excitotoxicity, which could be damaging to the brain. Your brain is very smart. It's going to downregulate, right? Remove receptors, and it's also going to make it desensitized. All right. So you might need a higher dose of medication or substances. Remember, I used an example of substance abuse last time. We talked about cocaine. Someone who's abusing cocaine, you're stimulating that dopamine receptor in the mesolimbic area, right? Which is nucleus accumbens, the reward pathway. And those receptors in the postsynaptic neuron are going to be very, they're going to be innervated so much that they're going to have to downregulate and desensitize. So in a way, you're going to need to actually take more substance to get that same effect because you don't have enough receptors and it's not as sensitive. So you have to flood the postsynaptic neuron with more neurotransmitter. Does that make sense? All right. So blockade, upregulation, increased sensitization. All right. Innervation, whether it's from medication, substances, or a regular neurotransmitter, sometimes you get desensitization and downregulation. All right. Important concept. We're going to be going back with that. Agonist spectrum, once again. Sorry, did someone write something on the chat? I can see my cursor was going on here. Someone write something in the chat, or you want to ask me? Or can I hear you, Professor? Oh, everyone else can hear me though, right? Roy, I don't know. Maybe it's your connection, but everyone else hears me. Agonist spectrum. All right. Once again, an agonist mimics the naturally occurring neurotransmitter. All right. That could be dopamine, serotonin, norepinephrine, all the other natural occurring neurotransmitters, acetylcholine, right? Histamine. Partial agonist can work both ways. It can work as a net antagonist or a net agonist, depending on the activity of that neuron. If there's high dopamine activity, what's going to happen when you give a partial agonist? It's going to have a net antagonism effect, right? It's going to lower the dopamine, innervation. So that could be an antipsychotic effect or anti-manic effect, right? If someone has issues with depression and they feel anhedonia and there's not enough dopamine, a partial agonist in that part of the brain is actually going to give dopamine, and it's going to give them energy, give them motivation, and also improve their mood, okay? An antagonist, obviously, is going to block the receptor. But even though you're giving someone an antagonist, it's always going to be residual activity still, right? Or intrinsic activity, that Stock calls it, in which there's still going to be activity there. Only when you give someone an inverse agonist, it's actually going to stop and fully close it, and there's going to be no activity. Is that clear? Any questions? Anyone? No. Pharmacokinetics, quick review. How the drug is absorbed, distributed, metabolized, and excreted. All right. So make sure you know your CYP enzyme interactions, like I mentioned last time. 2D6 is very important in psychiatry, but 3A4 in general medicine is the most common. 2C9, 2C19, and 1A2 are the things you should know. All right. There's also 2B6, 2B as in boy 6, but we only have a few meds that are metabolized by that liver enzyme. All right. Pharmacodynamics, how does the drug work in your body? All right, is it blocking D2? Is it blocking 5-HT2A? Right, so that's exactly, what the drug is supposed to do. All right, this is just a part of the brain that you guys should understand. So if you look at the brain stem, which is where the ventral tegmental area, notice it's all, in the bottom part of the brain, right? That's called the brain stem. And look at the connections, it's all going up towards the cortex. So in a way, when you're increasing serotonin, it's actually going to touch a whole bunch of different parts of the brain, right? It's going to affect the cortex, dorsal striatum, prefrontal cortex. Could be a good or a bad thing, all right? Sometimes the bad thing, because if you're touching parts of the brain you don't want to, you might cause increasing anxiety, right? You might cause increased appetite, which can cause weight gain, right? You might affect sex drive, right? Which is why some people have sexual dysfunction with increasing serotonin, right? Ventral tegmental area, that's one of the areas in which dopamine is produced. So dopamine is produced in two parts of the brain, more specifically, the ventral tegmental area and also substantia nigra. So those are the two cell bodies in the brain that produce a lot of dopamine, right? Raphe nuclei or raphe nucleus is one of the parts of the brain that produces most of the serotonin, right? And norepinephrine is produced in a part of the brain called the locus ceruleus, right? Locus ceruleus. It's not on this graph, but it's good to know. What is the monoamine hypothesis of depression? All right. So in simple terms, we believe that if there's not enough neurotransmitters in the brain, sometimes people can have depression, right? It's not as simple as that. It's actually a little more complicated. We're going to talk about that more. But there are some people that do respond to SSRIs, that do respond to serotonin reuptake inhibitors, and they do respond to DNRIs, right? So maybe their depression, quote unquote, has to do with not enough monoamines. But there are some people that have depression that don't respond to these medications. So is their depression different, right? It's possible, right? Because many things can have the same phenotype. Remember, phenotype is what's expressed out. So just because someone has a sneeze and a cough doesn't mean they have, I don't know, pneumonia, right? It could be different things. So one of the reasons why they had that hypothesis is because when you give someone a medication called reserpine, which is a vesicular monoamine transport inhibitor, which reserpine is actually meant they used to use for to help with oh God, I can't remember. Brain freeze. Sorry, we'll get back to that. But what reserpine does is when you use reserpine, it doesn't allow the vesicle to actually store your serotonin, norepinephrine, dopamine. So anything that's not stored can be eaten up, right? It could be eaten up by catechol-methyltransferase. It could be eaten up by MAOI. So in a way, you're actually depleting all those monoamines. So people who are giving reserpine, they're going to have a deficiency in serotonin, norepinephrine, dopamine. They realize those patients are going to have depression. Now remember, reserpine was used for hypertension back in the day, right? So by depleting norepinephrine, you're going to drop someone's blood pressure, but at the same time, you risk actually putting them into a depression, right? Does that make sense? Any questions? Yes.
Professor.
Yes.
So I have actually a question. How do we distinctly say that this depression is not a bipolar depression and it's just depression?
We're going to talk about that. We're getting there.
Okay.
That's going to be a big part of the topic too. Even though this course is not really for diagnosing, it's going to be hard for me to teach you about medications without going into diagnosing a little bit. So we're going to discuss that also.
Okay, thank you.
These are just some of the malfunctioning brain circuits, all right? Because I know in one of the goals of this week, we wanted you to understand parts of the brain that are actually implicated in some symptoms of depression. So in general, the prefrontal cortex or the frontal lobe is implicated in poor concentration, mental fatigue, guilt, worthlessness, and suicidality. Nucleus accumbens, the pleasure center. Remember, I mentioned that hyperactive dopamine in that area can sometimes reinforce behavior. So people might become addicted to something. So, but if you have issues in that area, you might have anhedonia, right? Things you used to love doing doesn't feel the same anymore, right? You don't really have pleasure in doing goal activity behaviors. You might have decreased interest, right? And low motivation. So by increasing dopamine, yes. Question? Question, anyone? No? Okay. So striatum is the motor pathway. So if there's an issue there, you would have something called psychomotor fatigue, right? So those are the patients that say, I have trouble getting out of bed. I feel like I have a weighted vest in my chest. I feel like I'm moving slow. So sometimes we call that psychomotor retardation, right? Or bradykinesia, very slow movements. And the opposite could be psychomotor excitation, all right? Hypothalamus, That's that part of the brain that regulates your sleep and your appetite. Okay, and you have your cerebellum, obviously, which is movement, coordinated movement, to be specific. Okay, we're gonna spend some time with this because I'm gonna keep explaining this until you guys understand or get sick of me explaining it. Okay, why do you think it takes so long for the medications to work? Did anyone read this? Can anyone try to explain this to me? Like what you read in the book and how you and why you think it takes so long for the medicine to work? Try to explain it to me. Anyone?
I read it, it's in Ettinger because I summarized the chapter, but it's hard to understand, like, it said, the lag time between drug-induced changes in neurotransmitters availability and any corresponding changes in symptoms can be up to 2 weeks, but it doesn't really,
Okay,
I'm
Very
trying to see why, and I don't, I think, I have it, but I just don't see it right now.
okay, no problem. So I'm willing to explain it and simplify it for everyone. So the reason why it takes so long, we believe, for the medications to work, because it has to do with that concept that I'm going to keep going back to, right? Upregulation and downregulation. All right. So it's not as simple as you're depressed because there's not enough serotonin in your synaptic cleft, or you're depressed because there's not enough dopamine or norepinephrine. Because those changes, again, which I mentioned, that have to do with the soma of the presynaptic neuron to the postsynaptic neuron, right? All those second messengers that they mentioned, has to take effect, right? And in order for downregulation, upregulation, sensitization, desensitization to happen, that cascade has to happen, right? And sometimes it takes a while for those genes to work. So when you give someone a serotonin reuptake inhibitor, what's going to happen is you're going to block the reuptake pump, right? So initially, what's going to happen is a lot of those serotonin neurotransmitters are going to stay in that cleft a long time. After a while, they're going to diffuse out and they're going to stop moving back. So if you look at this picture here, can you guys see my cursor? Can you see my cursor?
Yeah.
Okay. So see here, this is the where it communicates to the postsynaptic neuron. Eventually, some of these neurotransmitters are going to start flowing to the back to where the somatodendritic area is, right? But there's also some serotonin there as well. And what happens is once it goes back there, there's a negative feedback loop. So you have something called a 5-HT1A autoreceptor, or a serotonin 1A autoreceptor, which is sprinkled up there in the front. And then once those serotonin neurotransmitters bind to that receptor, what do you think is going to happen? It's going to shut it down, right? Which doesn't make sense. Like, wait a second, I'm increasing serotonin, but it's shutting it down. Why do I want that? But remember, when it shuts it down, eventually, sure, it's going to shut down the neurotransmitter release. But what happens when you stimulate a receptor over and over and over again by that person taking that medication daily, right? For weeks at a time, what's going to happen to the 5-HT1A autoreceptor? Is it going to downregulate, and is it going to upregulate and sensitize, or is it going to downregulate and desensitize? What do you think is going to happen?
Downregulate and desensitize.
Very good, exactly. So in a way, when it downregulates and desensitizes, you turn it off. So imagine cutting the brakes off of a car. All that car can do now is accelerate. All right. So once that autoreceptor downregulates and desensitizes, then that neuron is free to fire, and then it's going to flood. All that serotonin that was waiting before is going to come out, right? And that's the reason why we believe it's going to work. That's just part of the concept. What's going to happen eventually is those serotonin receptors are going to bind to all the numerous postsynaptic 5-HT 1A, 2A, T3 receptors, and it's going to cause a cascade that might cause neurogenesis, right? Increase of synaptic formations. Therefore, your depression will get better, right? Does that make sense? Once again, initially, you give someone a medication, right? You give them, I don't know, Prozac. It's going to artificially increase the serotonin there by blocking the serotonin reuptake pump, right? Once the serotonin reuptake pump is blocked, you're going to have a lot more free serotonin neurotransmitters in the cleft, right? Eventually, over time, those serotonin neurotransmitters are going to start moving to the front, right? It's just kind of like a what do you call that? Diffusion. When it diffuses to the back, it's going to start binding to that 5-HT1A autoreceptor, right? Which is a shutoff valve. Once the serotonin binds to the shutoff valve, initially, yes, it is going to shut it off. But eventually, once the serotonin keeps binding to that shutoff valve, it's going to desensitize and downregulate and shut off. Once it shuts off, that's when the serotonin neuron is kind of free. It's disinhibited, we call it, disinhibited to release as much serotonin as it can. And that's why it takes maybe 2 to 4 weeks for the antidepressant effect to work. Clear? I need to repeat
Question,
it.
actually. Which part of this picture is where the postsynaptic receptors are?
The postsynaptic is right here where it's circled. See these
Okay,
pink
cool.
right here? That's postsynaptic. That's like the head of the second,
Gotcha.
right?
Okay.
And this would be presynaptic, and this is
Yeah.
the somatodendritic area, right? It doesn't really show it here, but again, some of these neurotransmitters are going to move to the back, but there is slight release of serotonin as well in the soma area, right? And
Okay.
eventually that's also going to increase, and it's the same concept. It's still going to desensitize the autoreceptor, 5-HT1A.
Okay.
All right.
I have a question,
Yes.
and it may be a really ridiculous question,
No,
but so if we are increasing the serotonin and it's not actually hasn't gone past the receptor into the other neuron and it's basically free floating in that synapse,
Mhm.
my two questions are: is that effective as therapeutically, and how does that get to the bloodstream to check like levels of these things?
Okay. So
Sorry.
no. So what's in the bloodstream, right? We don't right now, we don't really have we don't routinely do blood levels for antidepressants, or whether it's dopamine, norepinephrine, or serotonin, because no one's actually done the studies to see
Okay.
how much medication is going to be in the blood plasma levels, right? And how does it correlate to clinical efficacy? We have that with antipsychotic meds, and they can do that with PET scans, like I mentioned last time, where they can see how much of the dopamine receptors are actually blocked and there's a clinical effect. But with serotonin reuptake inhibitors, we don't have any data for that. Sure, you could do a level, but it might not be any clinical significance other than the fact that the patient is taking the medication. All right.
Okay. And then
That's a
what
good
about,
question.
is it therapeutic in the synapse though? Because it hasn't gone to the other neuron. We kind of, we excited those receptors so more could go into the other cells, but now we have a whole lot in the synapse kind of region. So is that considered?
It might not be effective, yeah, until it actually binds to that postsynaptic neuron and the magic happens in the soma, right? And all those cascades
Okay.
happen. It's
Mhm.
probably not going to work. These are the patients sometimes that you give them. So good example, right? Someone is taking a medication that is metabolized by 3A4, right? Or 2C9. We use 2C19 actually, which is Lexapro, right? Someone gets a 2C19 inducer, right? They're taking the same dose. The inducer is causing your liver enzymes to eat up all the medication. So therefore, all of a sudden, it's not blocking the serotonin reuptake inhibitor anymore, right? So therefore, they're taking the meds, but you don't see an effect. So technically, it's a pharmacokinetic issue. But if you were to zoom in their brain and actually see this magic happen, you're not going to see anything happening, right? You're going to see the serotonin transport system still working the way it was, not being blocked by the medication, right? Does that make sense?
Yes, so that auto regulation shutoff kind of thing just basically leaves more in the synapse that can be put back in to the next
The
post-synapse.
serotonin transport, yes. Serotonin transport is
Okay, okay.
recycling, yes, it recycles.
Okay,
It.
cool.
Once you shut off the
Thank
recycle valve, yes, it's going to stay in there.
Thank you.
Sure.
I actually have a dumb question while we're on the topic.
Oh,
Oh, sorry. I think Teresa was going. Go ahead.
you asked me a dumb question, I gave you a dumb answer. Is that fair?
Yeah, sounds good to me. So my question comes in, I guess the best example of this would be, I was reading that you can get the early effects of an excess of serotonin, like nausea, et cetera, which
Mhm.
I understood was essentially mediated at like the 5-HT3 receptor, because a lot of that stuff, like, you use like Zofran as a receptor antagonist for 5-HT3.
That's correct.
So are there different flavors of serotonin? Like, is there different conformation of that molecule, or serotonin, and each of the receptors is just a different descriptor for how it's bound? Because my follow-up question to that is giving something like Zofran to counteract the early effects of an SSRI like nausea counterproductive to flooding that space with serotonin to ultimately achieve that down regulation? Does that make sense?
Yeah, no, it's a great question, actually. Yeah. Very, very in-depth thinking there. So yeah, when you give someone a 5-HT3 antagonist like Zofran, which is specifically made only to block the 5-HT3 receptor, no, because it's only blocking that receptor, but all the other receptors are naked, right? Like 5-HT2A, 5-HT1A postsynaptically, which can still have an antidepressant effect. So if you give someone Zofran, no. If you look at it from a general sense, someone who doesn't understand the brain, and you're saying, well, I'm giving someone a serotonin blocker and a serotonin agonist, right? So it's gonna be a wash, nothing's gonna happen. But like I said, the reason why it's important to understand all of those specific serotonin receptors, because you need to understand that specific drugs are only going to bind or antagonize or agonize only specific receptors. So if you give someone Zofran, it's not going to counteract the antidepressant effect. And I've done that. I do that sometimes. If a patient is like very anxious and is like, oh, every time I take an antidepressant, I feel nauseous. I'll give them like, I don't know, a month's supply of Zofran until it downregulates. And usually side effects like nausea, GI stuff, that goes away over time. Right. So if you can just get them comfortable taking it for that first month, usually it goes away. Did I answer your question?
Perfectly.
Professor, okay, so based on what you said, can we justify that SSRI, they don't block serotonin H3?
Well, there are some serotonin reuptake inhibitors that block 5-HT3. So I can't make that blanket statement. You need to know each medication, each med works differently. If I just say serotonin reuptake inhibitor in general, you don't know what I'm talking about. I could be talking about Prozac, Lexapro, citalopram, sertraline, Zoloft, right? There's a lot of meds. So no, the answer is incorrect. No, there are some antidepressants that block 5-HT3, like vortioxetine, right? It's a 5-HT3 antagonist, and it's also an SSRI, but it blocks a bunch of other serotonin receptors. So if you ask me that question with vortioxetine or Trintellix, I would say no. But if you ask me that question with Prozac, I would say yes. Any questions? I know it's a big topic. I don't want to move ahead unless everyone catches up. I don't want to lose anyone. Nope. Okay. All right, HPA axis. So this is another, hypothesis of why depression happens. All right. So the HPA stands for hypothalamic pituitary adrenal axis. And pretty much all it means is that the hypothalamus is going to secrete something called corticotropin releasing hormone, right? And it's going to innervate the anterior pituitary gland to secrete something called ACTH, which is a adrenal corticotropin hormone, and it causes your kidneys, the adrenal gland on your kidneys, to secrete cortisol, right? Once again, the same concepts of downregulation, upregulation are in play here, because over time, let's say someone is being abused, right? For instance, over months, and it goes to 6 months, it goes to a year. That HPA axis is constantly being overstimulated, and the adrenal gland is going to keep secreting cortisol, right? There is receptors on the hypothalamus and actually the hippocampus also called glucocorticoid receptors. So it's a negative feedback loop. After a while, normally, right, people get stressed out for, I don't know, a few minutes or even, 30 minutes, 20 minutes when you're doing something. And then after a while, the cortisol release is gonna touch the glucocorticoid receptors, and it's gonna tell the hypothalamus, shut off, stop, right? Stop secreting CRH, and then anterior pituitary gland is gonna stop secreting ACTH, and therefore cortisol is gonna stop. See, it's a protective mechanism. Okay, let me zoom in on the picture. Sorry. Okay, better. Let me see. Let me close this chat box. I'm sorry, I keep losing my cursor. That's why I minimize the screen. I don't know. Give me 1 second. Let's try this again. Okay, so hypothalamus, right, is overactive from stress. Your hypothalamus starts secreting corticotropin releasing hormone, stimulates the anterior pituitary to secrete ACTH, which leads to excessive cortisol release, right? The excessive cortisol release is eventually going to downregulate and desensitize the glucocorticoid receptors in the hypothalamus and the hippocampus, right? Same as the 5-HT1A autoreceptor that we were talking about, same example, right? Over time, what's going to happen? Once it desensitizes and stops working, there's going to be free release of cortisol, right? That's not good, right? What happens to too much cortisol? It can lead to cardiac issues. It can lead to increased sugar, cause metabolic issues. It also eventually will cause, your hippocampus to actually shrink. And once your hippocampus shrinks, your frontal lobe will also shrink a little bit. You're going to have a lot more mood symptoms. All right. Is that clear? Any questions? Sorry, I hit the wrong button. Okay. This is another hypothesis as to why depression might happen. And this is depression related to inflammation. Okay. So someone gets chronic stress. We have these microglia, or glial cells, which are some supporting cells of our neurons that become activated. And what that happens is the microglia are going to make, the permeability of your brain to open up just a little bit. And what's going to happen is you're going to have a bunch of macrophages and monocytes come inside, and they're going to do damage to your brain. They're going to start eating up parts of your brain, and that can lead to shrinkage of your hypothalamus. It can lead to shrinkage of your hippocampus, and it can cause damage. So it's almost like an autoimmune response, actually. The too much stress and chronic stress can cause systemic inflammation, and that causes microglia to activate, and pretty much monocytes and macrophages are going to go inside your brain and do damage. All right. So sometimes it might eat up some connections, so you might have less neuroplasticity, less neurogenesis, and it can lead to actually neuron or glial death. All right. And that can lead to mood, behavioral, and cognitive impairments. There's actually some, we don't really have any biomarkers right now in psychiatry. So biomarkers are like genetic tests that show, or any blood work that says, okay, you're positive for this, therefore you have depression. You don't have that. We do have some correlation. So there are some promising studies that people have elevated C-reactive protein, which is a sign of inflammation, respond to non-SSRI medication. So if you give someone an SSRI and it's not working, there is some data out there to say maybe you can do a C-reactive protein, and if C-reactive protein is elevated, they might do better on a SNRI or DNRI, or maybe even a tricyclic. All right.
Did you see that case about the woman? She was schizophrenic, catatonic,
Brain on
and
fire. Yeah. I've actually treated patients like that.
not that. She wound up having lupus.
Oh,
It was in yesterday's Times. And
Really?
then after, and they were saying inflammation, autoimmune inflammation can have these psychotic effects where they didn't think there was a treatment. And then she woke up after targeted therapies, which they didn't say what they were, but it was in
Wow.
yesterday's paper.
Wow. Okay. They probably gave her corticosteroids to kind of shut
Yeah.
down the autoimmune response. Yeah.
But it was lupus in the end.
Which is important, which is to why just because you're practicing psychiatry doesn't mean that you should have no general understanding of medicine. All right. Actually, working outpatient, I have a very good general understanding of medicine, right? I order a lot of labs. I send referrals all the time. I make sure I rule out hypothyroidism, and I pretty consult with everyone, neurologists, primary care. So it's you have to have a general understanding, all right? Since it's just a psychopharm class, we're not going to focus on that. But once you get to the clinical part, we're going to really focus on what labs to order and how to interpret labs before you start psychotropic medication. All right. Major depressive disorder. All right. This is just pulled right off from the DSM. All right. I use SIGI CAPS. It's pretty easy to understand. So issues with sleep. Some people might have insomnia or hypersomnia. Interest, lack of interest, right? It's called anhedonia. They might feel guilty or worthless. They have minimal energy. Sometimes we call that anergia. They have issues with concentration. They might not want to eat, or they might overeat. They might have psychomotor changes in which they might be, moving very slowly or moving faster. Usually if they're moving faster, I want to rule out mania. And they might have suicidal thoughts, right? Anyone know what residual symptoms of depression usually persist even after treatment? After you treat someone, what is it?
Isn't it like decreased concentration or cognitive issues?
Cognitive issues is one. Yep. Anyone want to give me another one?
Hypersomnia?
Sleep, not hypersomnia, actually insomnia tends to persist usually. Yeah.
Sleep.
That's sleep. So we have sleep, we have concentration. What's another one that persists? Usually doesn't get better. Energy. All right. Usually people will still have low energy. Our meds are pretty good at reducing mood, like reducing suicidal thoughts and helping with improved mood. But people still have residual symptoms. Also, they'll still say, I'm still forgetful. I still have issues with concentration, right? Maybe I have ADHD, right? Or we call that pseudo dementia sometimes, right? Long-term untreated depression can cause something called pseudo dementia. I still can't sleep. I have problems sleeping, right? And I still feel like I have no energy to do anything, right? Which is why we adjunct, right? Usually one SSRI or one antidepressant is not enough. We usually have to add different meds, right? I'm not going to read the criteria for you because you guys can read that, but again, this is not a diagnosing class, but I have a general idea so that you know how to treat your patients. Okay. Any questions? Okay, we're going to stay in this for a little bit because there's a lot of meds here. And you should have a general understanding of, if I say a medication, what class of med it is. I know there's a lot. There's like 7 SSRIs by themselves. And there's like a few, there's like 5 or 6 tricyclics. And of course, we have some monoamine oxidase inhibitors as well. And we have some atypical antidepressants also. But in general, our first line treatment usually is an SSRI or an SNRI, I'm sorry. Personally, I don't use a lot of SNRIs. That's just my preference. But there are some people that work in the same clinic as me that use them. I just find them very hard to get people off once they're on it. So I typically don't start people on SNRIs, but I'll also give a rationale for that, a more specific rationale a little bit later on. All right. So SSRI stands for specific serotonin reuptake inhibitor. Stop using selective because that's not really accurate. It's not scientifically accurate either. I know we used to say that in books, but we don't really have many selective serotonin reuptake inhibitors anymore, right? Sertraline, if you look at the style book, actually innervates the dopamine transport as well. So there is a little bit of dopamine activity there, not just serotonin. The only ones that really only act, if you want to be specific, that are selective serotonin reuptake inhibitors are actually Celexa and Lexapro, and they're enantiomers of each other, all right? Almost similar meds, all right? Paxil, obviously people can't tolerate it because it has a lot of anticholinergic side effects, and it also works on nitric oxide, which inhibits nitric oxide, which is why it causes really bad sexual side effects compared to the other medication. All right. There's Prozac. Oh, Prozac affects norepinephrine also. All right. So Prozac, believe it or not, Prozac and Effexor at low doses, Prozac actually has more norepinephrine reuptake inhibitor than Effexor. Only when you go above or at least 150 milligrams of Effexor do you get that norepinephrine activity. Below 150 milligrams, it's practically a serotonin reuptake inhibitor. All right. So if you're not going to push it up, why even give them Effexor? Just give them Prozac or whatever, Lexapro or Sertraline, another SSRI. All right. We have the tricyclics, which were one of the earlier antidepressants. So the first antidepressants in the market were actually tricyclic antidepressants and monoamine oxidase inhibitors. The reason why we stopped using them, anyone want to tell me why we stopped using tricyclic antidepressants? Why do you think we stopped? Well, not that we stopped using them, but we don't use them as much anymore. Why?
There's a lot of cardiac side effects.
There is, yeah. What
And they
else?
can take the whole month dose and overdose.
Very good, yeah. Very low therapeutic profile, right? What gets you well and what can kill you is very narrow. Not as narrow as lithium, but very narrow. Okay.
And
Anything?
also the dietary contradictions.
Not with TCA, that would be with monoamine oxidase inhibitors. Yeah. Okay. So with tricyclic antidepressants, in general, they have very strong anticholinergic effects. All right. So people will have issues with concentration because you're blocking acetylcholine. You might have blurred vision, constipation, urinary retention, typical anticholinergic side effects. All right. And also antihistamine. So patients will feel really tired. Sometimes we use that to our advantage. So people still give doxepin, right, which is a tricyclic for sleep, low dose doxepin, right? Off label, but it works. We use it for sleep for its antihistamine effect, right? But sometimes, if you want to get that serotonin norepinephrine reuptake inhibition, you don't need to use a tricyclic. You'd be more specific. You could use an SSRI, right, or SNRI, without the dirty drugs. We call it dirty drug because it affects other neurotransmitters that we might not want to actually affect, all right? So there's two forms of tricyclics. If you look in the book, we have secondary amines and we have tertiary amines, all right? And we're going to go into detail of why you should know that. Any questions with this slide before we move on? All right, these are side effects of antidepressants. There's a lot more side effects, but these are the ones that I see that are more common, and these are the more practical ones, all right? Like SSRIs, SNRIs, it causes sexual dysfunction because it innervates part of the serotonin receptor that impedes sexual function, all right? Some people believe it's because it innervates the 5-HT2A receptor, which actually downregulates dopamine. So when you don't have enough dopamine, right, you might not have motivation to have sex or not have pleasure, right? So that's why it can affect sex drive, right? It can affect erection and it also can affect libido. So it's, you might not be able to perform, they might not have a sex drive, right? GI side effects, right? Because we do have a lot of serotonin in our gut also. So usually it would be nausea, vomiting, diarrhea, sometimes constipation. And the drug that's notorious for that, SSRI, is sertraline, right? We call it squirtraline sometimes because it can cause a lot of diarrhea. Okay. Also possible induction of mania. So, it's important to diagnose someone appropriately. It doesn't always happen. And, if someone's not a good historian and they don't mention any hypomanic or manic episodes and you give them an SSRI and all of a sudden they become manic, then it could have been induced by the SSRI, okay? Bleeding risk. Right. Usually this happens when it's combined with other anticoagulants, right? Or someone's taking NSAIDs around the counter all the time. Okay. Some surgeons will actually, because I've had some patients that needed to get surgery, and the surgeon would tell them a week before the surgery to stop your SSRI because they don't want that risk depending on what the surgery is going to be. SNRI, it can cause acute liver injury, so we call it antidepressant induced liver injury. So I do recommend, and I do it when patients are on SNRIs, even though I don't prescribe them, patients come to me on them and they're stable. I do liver enzymes, so ALT, AST pretty regularly. I would say every 6 months. Okay. If someone's having like abdominal pain and they're having like nausea, vomiting, of course I would do it and probably send them just to be safe. Probably send them to primary care just to be checked out. Okay. DNRI, dopamine norepinephrine uptake inhibitor. The most common one is actually Wellbutrin, right? There's a seizure risk because it can lower the seizure threshold. Now it's not as bad because we have Wellbutrin or bupropion XL, which is called extended release version. It used to happen a lot more with sustained release, but you know, it's still a risk there, especially if they're using heavy alcohol, okay, or any other drugs that lower the seizure threshold. So just be careful. If they have eating disorder and they're purging, or you know, they're doing things, they have a head injury, right? Be careful with Wellbutrin, right? Because you might increase the risk of having a seizure. Tricyclics, once again, anticholinergic, antihistamine, alpha blockade. I forgot to mention that before. So they can have orthostatic hypotension. So be careful, especially if they're older and they're already on cardiac meds and they're complaining of dizziness. Just I would do a blood pressure and check, right? Now, if you look at this, less with secondary amines. Okay, so secondary means like an improvement of the tertiary amines. So tertiary amines are the older generation of tricyclic antidepressants. Those are amitriptyline, imipramine, clomipramine. The newer ones are nortriptyline, disipramine. Those are the ones that I usually prescribe if I have to, because they tend to have less anticholinergic, less antihistamine, and less alpha blockade. So they're more tolerable. Patients don't really complain about side effects with those. But once again, just be careful. You know, if patient has a history of suicide attempt or overdosing on pills, I would probably have a family member hold the meds and give it to them and make sure, just in case. Yes, Jessica, question.
Aren't the amitriptylines and all those also used for pain, like off-label uses?
They do, yes. So this is a pet peeve of mine, but I'll let you know. I argue and I yell at neurologists all the time when they don't tell me what happens to my patients. Because I sometimes someone could be on Prozac, right? And neurologist doesn't do what they have to do and they put them on a tricyclic antidepressant, right, which is a 2D6 substrate, and the patient all of a sudden is complaining of falling down or fainting or issues with ADHD. It's because of the tricyclic antidepressant, all right? So neurologists have a lot more meds that they can use to work with pain, right? Us in psychiatry, we only have very limited meds that might work with our patients. So you have to make sure that you put your foot down sometimes with other specialists and let them know, look, I'm not changing my meds, patient stable, you have to change your meds, all right? I'm very firm with that. Bipolar disorder. Okay, so again, this is not a diagnosing class, but just so you guys understand, this is just a short way of kind of shortcutting how to diagnose it in a freehand way. So hypomania is very similar symptoms to mania, but it's less, the duration is less, right? It's 4 days. A full manic episode is 1 week, all right? So that would be a period of they're distractible, they're irritable, very angry, grandiose, they might even be psychotic. Flights of ideas are having many ideas in their head, and when you talk to them, you can't interrupt them. So they're going to tell you a story. They might go from one idea to another, and you try to interrupt them, and you can't interrupt them. That would be considered flights of ideas. Okay. Activity increase, right? Sometimes you can see if someone's manic because they might do an activity, and every time you try to stop them from doing that activity, they get really pissed off by you. All right. You might ask the parents, have you ever observed your kid at night researching something online or cleaning the room, and you ask them, why are you up so late? And they get pissed off by you and they get really angry, and you see them up all night and they have to get that activity done. That's most likely a hypomanic or a manic episode, all right? Sleep, decreased sleep with energy. So I usually ask patients, have you ever had days in which you didn't need to sleep as much, or you were like up all night and you still had energy, didn't have to take naps, right? That will kind of give me suspicion that there might be hypomania or mania there. Talkativeness also is another one, all right? If someone has psychosis, usually that already breaks it. Even if there's only 4 symptoms, but they have psychosis, right? That's already mania. If someone has psychosis and they're not sleeping, they have a lot of energy, even if it's only 4 days, that's mania, not hypomania. Okay. Any questions with that? Is it clear? Okay. Okay, these are the FDA-approved medications for bipolar disorder. All right. So if you look at this list, we have a lot of meds that work for bipolar mania, but you don't have a lot of meds that work for depression. Bipolar depression is probably one of the most challenging presentations to treat because we have limited meds, and the meds are not that great, actually. All right. So, you know, you can use Depakote for bipolar mania. You can use lithium for bipolar mania, right? Lamotrigine, it says no for bipolar depression, right? But we use it off-label, and there's a lot of studies that show that lamotrigine is very effective in bipolar depression, right? But in a test exam, only stay on label for now. So the answer would be no. Can you prescribe lamotrigine for bipolar depression? All right. In a test exam, the answer would be no. In clinical practice, the answer would be yes. If a patient was euthymic and they needed a medication to keep them stable, if they're not manic and they're not depressed, you can use lamotrigine because that's maintenance treatment. Get it? Bipolar mania, they're acutely manic. You can give them any medication that's an atypical antipsychotic or Depakote or lithium. Okay. If they're depressed and they're depressive state, if you give them Depakote and lithium, it's probably not going to work. Right? Lithium can work actually. That again is off label. All right. But if you were going to FDA indications, obviously for the class and test exams, you would have to memorize this chart. All right. Maintenance, yes. Is that clear? Any questions with that? I mean, it's pretty self-explanatory. I mean, you just have to kind of memorize this chart and understand it. There's way more meds. Most likely, if they give you a medication, you don't know the answer, and they say, can you use this in bipolar mania? Answer is probably going to be yes, most likely, because there's way more meds for mania than there is for depression. But again, you should know this. Questions? All right, these are the mechanisms of action of mood stabilizers, and I want you guys to see a theme here. All right, so valproate or Depakote, MOA stands for mechanism of action. All right, it works on voltage-sensitive sodium channels and enhances GABA transmission. Okay, it enhances GABA by blocking the reuptake and breakdown of GABA by GABA transaminase, which is kind of like a monoamine oxidase for GABA. Okay, think about that for a second. So seizures and mood disorders are very similar. Okay, there's a concept called kindling. There was a psychiatrist named Robert Post who actually was the one who termed that term. And when he realized that there were rats that he had, and what he would do is he would stimulate the brain of these rats. And over time, once he kept stimulating the brain of the rats, they were more prone to seizures. All right. So then he realized and he postulated that, okay, seizures and mood disorders are kind of similar in a way that if someone has a depressive episode or a manic episode, their chances of having a depressive episode or a manic episode increases, right? You kind of see that. Patients who've been manic for a long time, their chance of becoming manic, it happens more. Like as someone gets older, they have more episodes as it kind of progresses, right? If they're not in treatment. So he recognized that pattern and he said, what about if I give someone an anticonvulsant and let's see what happens, right? So he gave these patients valproate and he realized that these same patients actually, they were less likely to cycle or have manic episodes on the valproate, okay? Because it works in voltage-sensitive sodium channels, which is overfiring in seizures, which also may be overfiring in the neuron when it's releasing, neurotransmitters, right? GABA is inhibitory, so when you increase GABA, the GABA will actually. So there's something called interneurons. It's not just simple as a presynaptic neuron and a postsynaptic neuron, right? There's also other connections in between, and we call those interneurons. So interneurons are in between the presynaptic and the postsynaptic. So usually we have GABA interneurons. So if we increase GABA, right, the GABA from that interneuron is actually going to tell the presynaptic neuron, shut off, calm down, right? So in a way, you're kind of indirectly stopping that presynaptic neuron by not blocking the postsynaptic receptor. Does that make sense? So you have two ways. You can either give a blocker of the postsynaptic receptor, right, which we do use. Sometimes we use atypical antipsychotics, right? Or we can give somebody a mood stabilizer, which works on GABA, which will increase GABA, and therefore it'll tell the presynaptic neuron to stop release. Does that make sense? You need to repeat it again? No. Carbamazepine, mechanism of action, same thing.
Sorry, could you repeat that again, what you said? Sorry.
Correct, yes. So there's two ways you can stop, overfiring of a presynaptic neuron to a postsynaptic neuron, right? You can either do it at the postsynaptic site by giving someone a blocker, right? Let's say it's excessive dopamine, the person is manic. You can give them Risperdal, right? Risperidone. The D2 blocker at the postsynaptic neuron. Therefore, the presynaptic neuron is overfiring dopamine when the person is manic, but you have a dopamine blocker there, therefore it's not working in essence, right? That's one way. Another way is we have something called a GABA interneuron. A GABA interneuron is a third connection. It's a connection to the presynaptic neuron in between the presynaptic and the postsynaptic neuron. So by increasing GABA transmission at that interneuron, which the mood stabilizers do, the GABA will tell that presynaptic neuron, it'll bind to that inhibitory site and tell it to shut down. So instead of blocking the postsynaptic D2 receptors, you're just going to decrease dopamine release of that presynaptic neuron by increasing GABA. Does that make sense? Sometimes we do both. We give them Depakote and we give them a quote unquote D2 blocker, right? Or antipsychotic medication.
Got it.
Is that clear? Okay. Carbamazepine, same thing. Works on voltage sensitive sodium channels, but also works on calcium, potassium, and enhances GABA activity. All right. So remember, by blocking calcium, you're stopping that neurotransmitter release, because remember at the synaptic cleft, you need calcium influx to bind to that snare protein to actually release the neurotransmitters, right? So by blocking that snare protein, even if you don't block sodium channels, right? Because the cascade's going to go down, sodium opens, gets to that last calcium channel, that channel is blocked, neurotransmitter is still not going to be secreted, right? So it doesn't matter. This is very important. Carbamazepine. Any patients who have Asian ancestry, you need to do a genetic testing. So you check them for an allele called the HLA-B1502. All right. That's important. Except if you don't like the patient, then you don't check it, because then they're going to die of Stevens-Johnson syndrome, right? High likelihood. Make sure that if a patient has Asian ancestry, you check them for HLA-B1502. All right, because they're at higher risk of developing Stevens-Johnson syndrome in carbamazepine. Okay, that hasn't been validated in lamotrigine. Some people say you might be able to with lamotrigine, but as of right now, it hasn't been validated, so I usually don't do it. Yes, question.
Hey, Professor, it's Jacob.
Hey, Jacob.
So I have a question. Going back to the GABA. So can you just explain the mechanism of action when GABA is when it gets when it's inhibited? What happens? Like it blocks reuptake. I'm sorry, the Depakote blocks reuptake of GABA. So what happens?
Okay, so GABA is an inhibitory neurotransmitter, right?
Yeah.
GABA is going to bind to the GABA receptor, right, which opens up chloride channels, and chloride is what? Negative. What happens when you make the inside of a cell negative? It what? Repolarizes the cell, right? When you repolarize the cell, it can't depolarize, therefore it can't release its neurotransmitter, right? So GABA, which is inhibitory, is going to open up chloride channels, which is going to make the inside of the neuron what? More negative, right? Sometimes hyperpolarized, it goes past resting potential, which is -90, right? -70 is resting, it might make it -90. Therefore, it's not going to be able to have an action potential. It's not going to secrete neurotransmitters, all right? That makes sense? Okay, going back to HLA-B1502, even if someone has mixed, I would definitely check it for carbamazepine, okay, of anyone with Asian ancestry. Okay, so if they're positive for that allele, you do not prescribe carbamazepine unless you don't like the patient, all right, or you don't like your license and you want to lose your license. Lamotrigine, mechanism of action, works on voltage-sensitive sodium, calcium, potassium channels and reduces glutamate release. Okay, what is an NMDA antagonist that works for depression? That's with a K, ketamine, right? NMDA antagonist. So by blocking glutamate release, in a way, it's similar mechanism, right? You reduce glutamate release, so you block the glutamate receptor. So that's why lamotrigine works well for depression. But remember, it's not FDA approved for depression, but it works for depression. There's numerous studies that show that. Okay, this is probably above the scope of this class right now, but just know that once you get really good in psychiatry, you're going to be prescribing a lot of off-label meds, because there's a lot of meds that are not FDA approved. Just because it's FDA approved doesn't mean it's the best treatment for a patient. There's many meds that I prescribe that are not FDA approved but are evidence-based, and the patients do very well on it. Lamotrigine is one of them. So I use lamotrigine off-label with evidence for bipolar depression, and I also use it as an adjunct for MDD as well. But again, in a test question, lamotrigine is only FDA approved for maintenance in bipolar disorder. Okay, maintenance in bipolar disorder. That's it. And it's an anticonvulsant, obviously. Any questions? Heavy topic, but Depakote mania works against mania. That's because it works on the channels and also has GABA. When you increase GABA, it tends to help with mania, right? Lamotrigine doesn't affect GABA. It works in glutamate, which is why it can work in depression, but it's not FDA approved for depression. Okay, is that clear? All right, that's all she wrote. That was the fun part. I can explain things again, or we can talk. There's so many, this is such a big topic. And remember, I'm doing another lecture tomorrow. I didn't talk about lithium because I'm actually saving lithium for its own lecture tomorrow. So we're going to talk about lithium for about an hour and a half also.
What exactly should we know with like, I know you were saying like the diagnosis for like the bipolar medications, like you just said with Depakote, Lamictal. For the SSRIs, how would you like kind of like ask a question more about like the doses and like what it treats, or like what else should we know about that?
The dosage, but I will ask you, patient has a past episode of hypomania, is currently reporting symptoms of depression, right? Low mood,
Yeah.
low motivation. Would it be appropriate to prescribe an SSRI?
Got it. Okay.
What would be your answer?
Well, if they have mania, I wouldn't prescribe. That wouldn't be my first thing to
No,
prescribe.
you wouldn't, because their diagnosis would be bipolar disorder, right? And SSRI
Yeah.
is not indicated for bipolar disorder.
Yeah.
If they've never mentioned any hypomania or mania, there's no family history, then yes, you would be
Yeah.
able to prescribe an SSRI or SNRI.
Got it. Okay.
Professor,
Yes.
so I have a question. This is related to the case scenario, right? So I was reading that people with taking TCAs, they can augment the therapy by adding lithium, right?
Yes. Okay.
I also found article that state that that was the practice back in 1980s and it was off-label. So I want to know if that practice is still in place or it's not
Of course, yeah, it could be in place, but as a student right now, since it's off label, like you said,
Uh-huh.
the answer would be no. Just because I don't want you guys to lose points on tests, okay?
Yeah, but
Because remember, yeah, anything that's off label, we can't really talk about it. But I'm letting you know just for your information, yes.
I just want to know because I want to answer to somebody about the TCA and I want to put that in my response, but then I couldn't find anything related that said that, oh, we're still doing it.
It's rare, but we still do it.
No.
Yeah, it's rare, but we still do it. Yeah. Alex, question?
Hi, Professor. Okay, I have two questions. One is regarding to the lagging time for example, SSRIs to start working.
Mhm.
I guess that the receptors, okay, so it's gonna inhibit the serotonin to be reuptaken, right? So I don't know, I didn't understand why take that time. Why it take 2 to 3 weeks to actually work?
Because it's not just the increasing serotonin in the synaptic cleft. You have to downregulate the autoreceptor, which more specifically is called the 5-HT1A autoreceptor, right? And the only way you downregulate a receptor is what? By stimulating it. So there's two ways you can actually downregulate an autoreceptor. By increasing serotonin, and it's just generally going to increase serotonin everywhere, right? And eventually some of that serotonin is going to bind to the 5-HT1A autoreceptor. But we also have medications that are 5-HT1A partial agonists, right? Like Buspar is a good example, right? You give someone Buspirone, and it's going to innervate that receptor. And after a while, when you keep giving someone Buspirone, it downregulates the 5-HT1A autoreceptor. Therefore, the serotonin will increase. And sometimes it's a strategy also. It's not really been validated if it actually works, but there are some case reports that if you give someone 5-HT1A partial agonist like Buspar on top of an SSRI, that it could downregulate the autoreceptor faster, and therefore they might have a quicker response. Okay.
Okay, so it's down regulation. We're waiting
Correct.
for the
Down regulation. That's the reason why it takes so long, because it needs the cascade to happen first, right? In which, remember, the nucleus of the soma of the presynaptic has to communicate with the nucleus of the postsynaptic receptor.
Okay, thank you very much. Another question. This is. Do you suggest any practice questions that you have? Any kind of resource that you might think about?
Not really. I can't think of anything. I was thinking about what you guys told me last week, and everyone was like, I want, can you guys give me a study guide or a breakdown? But to be honest, the answer is no. And the reason why I'm saying that is because I expect you guys to rise to the occasion, right? My job here, if I'm doing my job, is to give you guys all the information that's needed, and you guys need to rise to that level, right? You can't say I'm not answering emails, I'm not giving you all the material, I'm not answering any questions. And it's up to you to kind of like read all that stuff and understand it, all right? It's been done. I did it. A lot of people graduated. I've done it. So by me lowering the standards, I'm actually kind of giving our profession a disservice, right? Because you guys are going to be practicing. So it is realistic. Trust me, in 6 weeks, you guys can learn this stuff. It's a lot of material, but you can do it. Trust me, it's possible. It's how much do you want it though, right? Yes, question, Teresa.
Yeah, so how, in Alex's question made me think of this question, and how is the half-life related to that lag time for the drug to become therapeutic? Is it related, or is it
No,
that
not
just the
related.
half-life, just how long
Half-life
it
is
stays
not,
in your system?
Um,
It's just how long it stays, not how long to get going.
Yeah, when it comes, half-life sometimes can work But for some reason, with antidepressants, half-life is not really an important part. Once again, we're not really sure of the full picture. This is all just hypotheses that is downregulation, might be a different mechanism. But half-life usually does, right? If something has a short half-life, it can work faster and hit steady state. But for some reason, even a med like Prozac, well, actually, sometimes Prozac does take a little bit longer. If you read the style book, it does say, because of the long half-life, sometimes it might take a little bit longer. It might be like a week or two lag time as opposed to Lexapro. Have I seen that in clinical practice? No, I have seen patients respond to Prozac in like 2 weeks.
Okay. Thank you.
Because you would think if that was the case, Paxil has such a short half-life, which people have terrible withdrawal and bad side effects from it, that Paxil should work in like a week, right? Because the half-life is so short. But we don't see it
Right.
either.
Exactly. Okay.
Can you hear me, Professor?
Yep, loud and clear.
Okay, I just had questions about the CYP enzymes. Like I know that they're important, and like there's the list of them, but I couldn't find in the reading just like a chart of like just like known drugs that act really significantly on like one in particular.
We put up the Flockhart chart on the first week. Did you see it? Or
Oh, is
Flockhart
it?
chart on the second week? It's called Flockhart table.
Okay,
If you look that up, it has all of the meds on there and what substrates they are and if they're inhibitors or inducers.
okay, it's listed in the week 1.
Yeah, Flockhart table. Look for it. It's there.
Okay.
How you doing, Professor? Quick question. You mentioned a lecture tomorrow on lithium. Is that going to be recorded?
Yeah, all lectures are going to be recorded. Yeah.
Awesome. Thanks.
I'm specifically going to hold a lecture on lithium for at least an hour because I think it's an important medication that a lot of people have forgotten how to prescribe effectively, and it's underutilized. And I use it a lot with a lot of my patients. It's really life-changing. So we're going to talk about how to prescribe it, how to monitor it, right? All the ins and outs of it tomorrow.
Professor Collado,
Yes.
are we gonna be able to use our notes or having it close by during the test or no?
Oh, everything is yeah, it's not open book. I'm sorry.
No? Okay.
Professor, for the case study, like just, do you want us to respond just once, or like you post your responses and then do you need a certain number of replies to complete the assignment?
Yeah, minimum of at least one, I believe. I think that's
Okay.
what Professor Smith put, right? I didn't grade your responses yet. I'm gonna look at it this weekend, everyone. But yes, I believe Professor Smith mentioned that there should be at least one response. So
Okay.
okay.
Just one. Okay, thank you.
I don't, if you want to respond to everybody, that would be great too. Did you find out the time for the exam? No, we're actually working on the exam now with the questions. So I'm actually going to vet the exam to make sure that, that it's fair questions for the stuff that we're covering. But, there might be a few questions out there that are in the reading just to keep you guys honest, because of course, there's a lot of stuff that you need to know, but majority of it's going to be on the stuff that we're covering, or at least related to it.
Professor, how does it work if we want to take the test at the School of Nursing next Friday?
Let me find out for you. Do you want to actually go in? Is there a reason why you want to go in to do it?
I've never taken it with the Respondus. Do I have to download something, or is it just part of Chrome?
I think you have to download it. You have to download it. Yeah. Let me find out for you, James. Let me. Can you write that to me in a formal email so I can forward it to the right people?
Certainly.
Professor, I don't know if this happens to somebody else, but the first week I tried to use Respondus to actually try to do the check-in, but I was able to actually do the check-in without Respondus. So I wondered if it, just because it was the first week, maybe that was a mistake, or maybe there's something
Maybe it wasn't turned on because it wasn't a test. I'm not sure.
Oh, okay. All right. It's just because this is the first semester using Brightspace. So I was wondering if I did something wrong.
Just be careful of respondents, because I've heard stories of students that say if you have, like, I don't know, Britney Spears picture in the back while you're doing your test, it might capture that face of whatever you have in the back as there's another person in the room. So if I were you, I would take off any posters that you have, right?
Oh, I had to take it down.
Professor?
Yes.
Can you were you able to find out if there's a time frame to take the exam, and how long we could take the exam, like how many minutes is allotted?
Let me find out. I know the exam is gonna be open for, usually open for like 24 hours, but once you start it, there's gonna be a timer. Like you can't just.
Yeah. Is it like gonna be an hour and a half? Is it gonna be an hour?
We're still filling out the questions, so depending on how many questions are on the exam, we'll let you know what the time is. All right, because we're not sure if it's gonna be 50 questions or 100 questions. We're still working that out.
Thank you.
All right. Any questions?
I guess I do have a question since we're talking about this. Is there a way to check? I mean, I've never used Respondus before. I don't imagine that I'd have a problem, but is there a way that we should be like checking it? Because I also, we didn't need it for when they did the check-in. So is there a way that we can check it before the exam to make sure that we don't run into a problem that day?
Respondus is like it's outside, it's like a different entity from us. So maybe
Okay.
Respondus itself, is there an email for them to ask them that? Because I don't really know the answer. I don't want to give the wrong answer. Maybe they
Okay, I can
enable it somehow for
can
you?
check.
Yeah.
Sure, okay.
I want to make a suggestion with the responders because I'm in 2 classes. So I'm in the psychopharm and I'm also in patho. So with the psychopharm, I was able to do the responders test. However, with my other class, it's still kicking me back to Blackboard, which is what we had last semester. So I would test it before the test.
Yeah, definitely make sure that it's just working. So I don't want.
Yeah, I
you guys-
have IT working on mine right now, but I still can't get into it. It keeps kicking me back to Blackboard.
How did you check it?
You could do a respondus quiz. So I
Oh,
have it with
okay.
my other classes, so I tested it just to make sure it works. It works with psychopharm, what we're taking now, but it's not working with my pathology class. It's taking me back to Blackboard. So they're
And
trying to see. what
is the
comes through.
Respondus quiz on like a Respondus website where they're like, oh, here's how you can check if Respondus is working with your system? Is that how
They
it
had
works?
sent it to us. They sent it to all of us in our classes, and I don't know how I got it in the psychopharm, but it does get me in there, but it doesn't get me in the other one. You can contact IT. They're pretty good at answering because they're working on mine currently.
Okay, all right, thank you.
All right. So I know I kept it very brief in this because there's just so much to cover, but I want you guys to understand the gist of like how to treat a mood disorder. All right. So in general, did you guys read the article on the STAR-D trials? I know we posted it up there. I know some of you probably didn't read it, but STAR-D trials, we cited it a lot. So there's 2 studies that I really want you guys to know the ins and outs of. All right. STAR-D, and the CATIE trials for schizophrenia. So STAR-D is the first trial in which it actually has a large cohort. It happens with a bunch of people from different outpatient clinics. And what it showed was that our meds are not that great because the people who responded during that first part, so it was different arms of the trial. There was about 4 different arms. And that first arm, only 33% or 30% of patients actually got better, right? On that first. On the people who didn't get better, they stayed in the study and then they were either augmented, they added another medication, or they switched them to another treatment, right? At that point, I think it was like 20% got better. And in the third arm, it was less than that. And the fourth arm, it was less than that. And it kept getting less and less. The point of the story is that people who don't respond like the first time, their chance of responding the second time, the third time, the fourth time gets less and less, all right? Which is why sometimes people have depression, just MDD by itself. They might be on like 3 or 4 different medications, right? They might be on, I don't know, Effexor. They might also be on, aripiprazole as an adjunct, right? They might also be on thyroid. I prescribe thyroid as an adjunct also. Patients are treatment-resistant depression. I use it also. I use T3, all right? I also use lithium a lot as an adjunct as well. I also use atypical antipsychotics as an adjunct also. Because serotonin reuptake by itself is not enough, right? Because you have to target specific parts of the brain to work, and just increasing serotonin blindly or norepinephrine is not going to do it. Because you're going to innervate some receptors that are good for the patient, and you're going to innervate some receptors that are bad for the patient, right? So you might have to use some antagonism to kind of balance it out. Does that make sense?
Where in the reading were those trials? I don't know if I read.
Trials. We actually posted the trial on there. If you look at, there's Professor Smith put it up there. It's called the CATIE trial. C8. I'm not Katie trial. I'm sorry. Star D. Katie's gonna be when we go to schizophrenia. Right now, we're talking about the Star D trials.
For that star D, do we need to know like specifics or just like the fact that it gets less and less as time goes on?
Just a general idea that, usually switching is not as effective as augmenting,
Got it.
right?
Okay.
That's like the main point. That study showed that augmentation was superior to switching, usually, which is why you see a lot of people, augmenting. So in a general sense, when do you know when to switch and when do you know when to augment? Anyone want to try to answer that question? When do I switch? When do I augment for depression?
Side effects.
So I was switching with side effects, or I was switch?
Switch if they're having side effects, significant.
Great. Okay. Good. And what's another thing that you would probably do? Switch if they weren't what? They were having what? No response, right? So if they're having if it's a tolerability issue and they can't tolerate it, now I feel more anxious or I feel like it's killing my stomach. I always have to use the bathroom. And of course, switching might be a good option, right? But if there's some improvement, right? Usually the rule I like to use is 20% in 2 weeks. So in 2 weeks of being on that medicine, there's a 20% improvement. They say, well, I have a little bit more energy. I'm sleeping a little bit better. I have a little bit more drive, and sure, I'm going to keep it. All right. And maybe maximize that med. But now, let's say, for instance, you're on Lexapro 20 milligrams, which is the top FDA indicated dose, right? And there's still residual symptoms of, I don't know, low motivation, low energy, and they're having sexual side effects from SSRI. What would be a good option to add and why? As an augmenter or an adjunct?
Wellbutrin.
Very good. Yeah. Why? What does Wellbutrin do that the other med doesn't do?
Then Wellbutrin adds more energy and it has less side effects than the.
Yeah, but let's talk neurotransmitters. Talk to me about what does it increase?
Norepinephrine.
That's one. Good. And what's the other one?
Dopamine.
Very good. Right? By increasing dopamine and norepinephrine, you're also giving them energy and you're giving them increased motivation, right? And combating the sexual side effects from the SSRI that's down regulating the dopamine from the innervation of the 5-HT2A autoreceptor. All right. There's autoreceptors and dopamine neurons that are 5-HT2A. What happens when a medicine hits that autoreceptor? It shuts down dopamine release. That's why SSRI sometimes can cause symptoms of EPS, actually. If someone's on SSRIs long enough, or they stay on it long enough and they have high dose of it, it can cause EPS. Akathisia. I've even seen dystonia on patients with SSRIs, which is a dopamine issue, right? But you're decreasing dopamine by increasing serotonin. Does that make sense?
Can you explain that? Oops.
Yes.
Thank
So
you.
So let's say you have a dopamine neuron, right? It has receptors for all different neurotransmitters on. There might be acetylcholine, there might be serotonin. We call those heteroreceptors. Heteroreceptor means that there's a receptor on a neuron that spits out a specific neurotransmitter that's different than the neurotransmitter that is spitting out, right? So for instance, a dopamine neuron doesn't only have dopamine receptors on there. There might be serotonin receptors sprinkled in also that could be inhibitory or excitatory. So on dopamine receptors in the nigrostriatal area, right? Some of those dopamine neurons have 5-HT2A autoreceptors. And what's an autoreceptor? It's a shutoff valve. So if you give someone a serotonin reuptake inhibitor, right? What's going to happen is those nearby serotonin receptors are going to increase serotonin, and some of those serotonin receptors might actually sprinkle up to the dopamine neuron that's next to it, right? And once it sprinkles up that dopamine neuron that's next to it, it might bind to a 5-HT2A receptor on the dopamine neuron, which is going to tell a dopamine neuron to shut off. So when it shuts off, what's going to happen? Not enough dopamine, and you're going to have movement disorders, right? Or dystonia. Does that make sense?
Yeah. Does it only happen with dopamine and serotonin, or does that happen with norepinephrine?
No, all of them.
sometimes?
They all have.
Oh, great. Okay, so it's not simple.
Very complicated. But you have to understand the concept, though. Like I said, if you just understand autoreceptors, heteroreceptors, postsynaptic, presynaptic, right? You can kind of figure it out. The confusing part is you can have the same, let's say you can have 5-HT1A receptors, right? On the presynaptic as autoreceptors, but you can also have 5-HT1A postsynaptically as regular receptors. Did you know that? So if you make a blanket statement like it's a 5-HT1A agonist, okay, is it going to work postsynaptically or is it going to work presynaptically? Or is it going to work on both? Most likely it's going to work on both, right? You give someone BoostBar, it's going to innervate the 5-HT1A presynaptic autoreceptor, right? And shut off the release of serotonin, eventually downregulate it, but it's also going to work at the postsynaptic, binding to the 5-HT1A postsynaptic receptor there also, right? Because we don't have meds that are specific. When you give a medication, it disperses in your brain and it binds to every receptor that it has affinity to. Give me one second. I'm going to show you guys something. Let me just make sure. This is not meant to like scare you and intimidate you, but just giving you an idea of how complicated things are and why it's better to understand it than actually to memorize it. Because if you try to memorize it, good luck, you're never going to get it. Give me one second. Let me share this. This is Wikipedia, not the most scholastic website, but it does do a decent job of explaining receptor binding affinity. Give me one second, let me zoom it in for you. Can you guys see? Is it close? So this is for Abilify. I just picked it randomly, aripiprazole, okay? Where's the binding sites? I'm looking for the pharmacokinetic part.
I just saw it at the
Pharmacokinetic.
binding.
Perfect. Yep. There you go. Just looking for the. Usually here. That's odd. It actually usually shows all the receptors on here. All right. Pick a different method to risperidone. This will make sense once I show you this graph, and I'll explain it and break it down to you guys. Okay, perfect. Right here, risperidone. See this little graph here? You see these numbers? All right. See, there's like 423, 14.9. This is called KI value. I don't know if you guys remember from your pharmacology class, but KI value is very important. And remember, KI value is the inverse of 1, right? So it's 1 divided by number. So if you remember that, actually the lower the number, the more significant that it is. All right. So 423 is not as significant as 6.60, or even better, 5.0. So an affinity of 1.30 is actually significant. Remember, it's 1 divided by that number. Okay. The reason why I'm saying that is because if you have 2 drugs, for instance, right? Someone's taking risperidone, and the KI value of risperidone on the D2 receptor is 3.57. Okay. You give someone aripiprazole. The binding affinity to D2 receptor of aripiprazole, I think, is less than 1. It's like point something. What's going to happen? Who's going to win at the receptor site? What has higher binding affinity? Aripiprazole, right? Abilify. So all these receptors in the brain have a certain binding affinity, and so does your regular neurotransmitters as well. The reason why I'm bringing that up is because I don't know the actual binding affinity memorized of the regular neurotransmitters, but those KI values would determine, if you flood the brain with a bunch of molecules, which one is going to win at the receptor site, right? So you give someone Abilify and risperidone at the same time. Abilify might beat risperidone at D2 receptor, but risperidone might beat Abilify at the 5-HT2A receptor, or risperidone might beat it at the anticholinergic receptor. Get it? So all these receptors are kind of in flux. All these neurotransmitters are in flux, and it's going to bind to different receptors. Is that really confusing? Did I blow your mind? Are you guys lost and confused? I'm sorry. That's not what I wanted to do. It's just making you understand why it's important to understand these concepts and not memorize it. Because if you understand the concepts, you can easily break it down by looking at this. All right. But if you memorized it, you wouldn't be able to understand it. Questions? I have to get off at 12:30 today. So we have 10 minutes. So any
Uh,
pressing questions, please?
Professor, is it possible to for the PowerPoints to be available from
Yeah,
today?
I put them up this
next-
morning. I put them up this morning in the announcements.
Oh, okay, great.
Yeah.
Thank
Yeah,
you.
this PowerPoint is on the announcement. I knew you were gonna ask me that, so I put it up early.
What time is lithium tomorrow?
Lithium, what would I put? I think from 1 to 3. I wanted it to be a little bit later on, so you guys had time, because I know some people can't make it on the weekdays, so I wanted to make it on the weekend.
Cool.
I'm willing to
Thank
go 2 hours if I have to. All right, if we can do it in an hour, we can. But we're gonna do a deep dive of lithium tomorrow.
You'll definitely record that too, right?
Of course, everything will be recorded.
Okay, thank you.
Professor, I just had a question. So, can you repeat the SSRI action? I know they all, there's 6 different, they work, there's a main mechanism and then there's 6 different medications that have different properties. But the main mechanism is basically at the presynaptic, then the somatic, I'm not sure if I'm saying it right, the dendritic somatic site, the serotonin increases and then it down regulates and then it disinhibits the neuron to release serotonin in the postsynaptic cleft. Is that basically what the mechanism is?
Yes, so it works on SERT, S-E-R-T, which stands for serotonin transport system. So what's going to happen is the medication is actually a false substrate and it's going to bind to those free receptor sites that normally the serotonin will bind to, right? So when all those receptor sites are fully booked up with the medications, serotonin can't go inside, right? So serotonin can go inside, they tend to linger in the in that space, which is called the synapse. So therefore, eventually all that serotonin is going to disperse, right? Start moving to the back, start binding to 5-HT1A autoreceptors. Initially, the autoreceptor is going to shut it down because it's an autoreceptor. But over time, that autoreceptor is going to get stimulated by serotonin constantly. It's going to do what? It's going to downregulate and desensitize. So once it downregulates and desensitizes, technically it shuts off. Once it shuts off, that presynaptic neuron is disinhibited and it's free to secrete as much serotonin as it wants. Is that clear?
Yes, thank you.
Eva's dad was like a public speak to the supervisor. So apparently, first, so he's got a lot of complaints.
If you're not asking a question, please turn your mic off. Any other questions? You have 7 minutes. Come get your money's worth. You guys were complaining that there was no live instructor last semester. You guys are getting it now. Take advantage. You can repeat something that wasn't clear. You can clarify anything.
Next Friday, the exam is on what we're learning today, tomorrow's lithium lecture, and then last week,
Yes.
nothing that we're going to be reading starting Monday for week 3.
You know what? Let me clarify with Professor Smith to see what he wants to do. All right.
All
Would
right,
that be unfair if it was your reading for next week also? It's a short course. You're like almost halfway done already.
well, I just want to know where to focus the studying.
That's a fair question. I'll get back to you by the end of today. Let me just check in with Professor Smith.
Thank you.
I have a question that maybe I should already understand. Each medication, where do we know what part of the synapses they affect? Does it say in like the drug guide specifically about it, or where do I find that information? Or does it change? Is it a set thing with each medication?
It is, and it wouldn't be fair for me to tell you, even though I know, but I don't expect you guys to know that. Right now, in general, just know it works in the synaptic space. All right, in a general sense.
Okay.
Yeah, it wouldn't be fair for me. There are meds that work presynaptically, and there are meds that only work postsynaptically. But at this point, we'll just keep it postsynaptic.
Okay, thank you.
Psychopharm and psychiatry is very complicated. So, I want you guys to really appreciate it for what it is and take the time to understand all the basics. It'll get easier over time, trust me. It'll get much easier. As long as you take the time to understand all the basic fundamentals of it, upregulation, downregulation, pharmacokinetics, pharmacodynamics, what each receptor does, right? In a general sense.
I have another question. So should we really focus on the class of meds like the SSRIs, or do you want us to know the difference between each drug in the class and what they do, or generally which class they fall under?
I would just in general what class they fall under. I'm not going to ask you what's the difference between Lexapro and Zola. All right.
Okay, but we need to identify which meds are in which class.
Correct. Yeah, you
and
should
how
know
the
that.
class
Yeah.
works. Thank you.
You should know that.
Perfect.
So remember, TCAs tend to end with the same suffix at the end, right? Tryptoline, amitriptyline, nortriptyline, dicipramine, right? That's easy. It's kind of like antibiotics. But SSRIs, it's a little bit harder, but it's only like 5 or 6 of them. You should be able to understand them, memorize them. Wellbutrin is the only one that's dopamine norepinephrine reuptake inhibitor. That one's easy.
I have one more question that may not be specifically about the exam, but it's about the psychopharm and generally. When I was doing the case study and I was looking to decide which meds to start first and second, I was trying to find like a clinical guideline that just had like a recipe on which ones are first line, but all I could really find were different articles that said, several different things. Is there a guideline, or is that something that I'm not sure if I was misled on that kind of thing.
There's multiple guidelines. So if you're going to follow a guideline, there's different. But in general, SSRIs are first line. But depending on what guideline you look at, it might recommend a different SSRI. There might be a guideline that, like the Harvard, the one I used to follow, what they would recommend sertraline as first line, right? But if you go on like the Florida CPG guideline, it might be like, Lexapro or something. But again, it doesn't really matter. I mean, they're similar enough. But the answer is guidelines are all different. But in general, they'll recommend SSRIs as first line if someone has MDD, because it's relatively safe, it's tolerable, you can't really overdose on it, right? But whichever SSRI you choose, it's really up to you. But if you're doing child psych, if you want to stay FDA approved, it would be Prozac or Lexapro. Those are the only 2 meds that FDA indicated in MDD in children and pediatrics. Since I work pediatrics, I know. I know you probably all need some time to digest all of this. This was a pretty heavy topic. I didn't want to hit you all over the head with like a sledgehammer, but it's a lot of stuff to understand. But again, it's going to keep building. So I'm going to keep reviewing like next week again, our next set. I'm going to go back and discuss today and the first weeks. All right. We're going to kind of keep going over and over again.
When will you let us know about if this upcoming week, like the anxiety lecture is going to be on the test coming up?
I'm hoping by the end of today, I'm gonna email Professor Smith as soon as this ends and see what he tells me.
All right, cool.
Because you have a choice. Either the anxiety is going to be in the midterm or it's going to be in the final. But if you wait, that's just going to be more material for you to have to do for the final, right? So it's either you get it done now or get it done later. You still have to get it done. So what do you guys prefer?
Sorry, Professor. One question. The final is not a cumulative test, right?
No.
It's just the last 3. Okay.
Yeah.
I thought it was cumulative somewhere, but okay, that's good to know.
You might like throw a couple like questions, and that's for your benefit, just because you'll remember those questions from the beginning. But in general, it's not going to be cumulative. Last minute. Any other questions? No.
So, Professor, I'm sorry. I know we're like all obsessed with the exam. Like you mentioned, knowing like the drug classes and the mechanism of action and like the big picture kind of stuff, like understanding that.
Okay.
Like I know, like just for example, like the SSRI classes, there are drugs that have like, special like things like the sexual dysfunction with paroxetine, like withdrawal symptoms, like just knowing like kind of really special things about drugs within each class. Like would you recommend like focusing on this thing?
You should, let's talk about SSRIs. You should know that paroxetine has the shortest half-life, right? And fluoxetine has the longest half-life. Fluoxetine, the downside is that if you're having bad side effects from fluoxetine, once it hits steady state, it might take a month for the fluoxetine to flush out of your system. All right. All right. I'm gonna stay an extra 10 minutes because I want to explain this to you guys. So it's a big picture, so you can really understand why it's really important. Okay. So I had a patient that came to me a while back, maybe a year ago already. And when I asked them, what meds were you on? They like, I don't know. I don't remember what meds I was on. It was a pediatric patient. They were 16. And I put them on aripiprazole, put them on Abilify, right? 2 milligrams only. And as soon as they put them on Abilify, they started having side effects. They were having akathisia. They were even having some like stiffness, which is, rare with a partial agonist, but can happen. And I realized later on that they were actually on Prozac. And it was like 3 weeks ago that they stopped it. The reason is because the Prozac stays in the system for so long, and it's a 2D6 inhibitor, that any med that's 2D6 that you put on board after that is going to be increased. So the 2 milligrams of Abilify could have been like 10 milligrams or maybe more, right? Does it make sense? That's why it's important to know these CYP enzymes and the half-life also. I tend not to prescribe fluoxetine in adult patients because adults and older adults that I treat tend to have a lot more other meds on board. So the Prozac is going to inhibit all those other meds, and with a long half-life, it's going to increase the dose and they might have side effects, right? So I try to stay away from that. I'll try to use Lexapro, escitalopram, which doesn't have any CYP enzyme inhibition or doesn't affect all the other meds, okay? Paxil has a short half-life. It is also anticholinergic, therefore it can cause a lot more cognitive issues, all right? Blurred vision, issues with concentration, and it has a short half-life also means that once they stop it or they miss a dose, their brain is looking for that medication because the half-life is so short, they can have withdrawal symptoms, all right? So sexual side effects is not just Paxil. It can cause worse than the other ones, but all of the SSRIs can cause sexual side effects, right?
So know some like caveats about like those, like each med in the classes within the class.
Yes, know that SSRIs have a lot of GI side effects and have CYP enzyme interactions, right? More specifically Paxil and fluoxetine. Bupropion can cause seizures and also is a 2D6 inhibitor, so know that. I also know that SNRIs, since they increase norepinephrine, can increase heart rate and blood pressure also. So if someone already has hypertension, I would probably not put them on an SNRI, okay? And if someone has liver issues, I probably would not put them on an SNRI. Remember, because it can cause spontaneous antidepressant liver injury. All right, tricyclics, be careful with patients who have history of overdosing on meds, because tricyclics, they can take all of it and have, cardiac arrhythmias, all right? And monoamine oxidase inhibitors, it can cause hypertensive crisis if they have aged meats, salts, wine. Okay, if you give them the patch, there's no dietary restrictions, right? You can give them the selegiline patch, but normally in general, just know the monoamine oxidases can have that side effect and just a dietary restriction. Okay, except if they have the patch. Any other questions? Do not give SSRIs or monoamine reuptake inhibitors to patients who have bipolar disorder. It's a pretty well known that number one, either it doesn't work or it worsens the presentation of the patient. They can be rapid cycling or it can actually make them manic. If anyone has bipolar depression, you can use Latuda. That's FDA approved for bipolar depression. You can use Seroquel, quetiapine. Quetiapine is one of the few meds that's actually FDA approved. It's broad spectrum. Think of it like antibiotic, covers everything, right? It's for maintenance. It works for depression and it works for mania. So if you're not sure and someone only wants to be on one medication, that one med probably would be best to be quetiapine. But just be careful because quetiapine has metabolic issues too. It can cause diabetes type 2 if it's not controlled. They usually put them on metformin, or it can also cause a lot of weight gain as well, right? So metabolic symptoms are big with quetiapine and sedation.
Claudio, isn't it true that until not too long ago, they were giving SSRIs to people to rule out bipolar?
Yeah, that's like giving someone alcohol to find out if they have alcohol use disorder.
I know, I always had issue. I always thought it was kind of a gross practice, but
you guys are not going to do that, right? Anyone?
No, we're not doing that.
When you guys get to the clinical part, and if you guys, you're my class, you can understand I'm very particular and very specific. All right, any other questions?
I'm sorry, you went out. What were you very specific about?
The way I practice.
Okay, thank you.
Yeah, I don't believe in like blanketly prescribing meds to people without actually understanding like what's happening. So I'm very like particular. I do blood levels. I do a very good interview and make sure that, you know, patients, because sometimes there's a perception in psychiatry that a lot of us do trial and error. There's a little bit of truth to that. I'm trying to move away from that. There's no such thing as trial and error. All right. You should have a general understanding of why you want to give certain medications. Okay. So if someone comes to your office and they say, well, you know, I've been depressed for a couple of months, and okay, what type of depression do you have? Well, I have, you know, poor concentration, low energy. And then they say, okay, these are your options. What would be a deal breaker for you, right? What kind of side effect would make you stop taking your meds, right? And if they say sexual dysfunction, because they've heard about it, then of course, that would rule out any SSRIs. I would put them on Wellbutrin, all right? If their issue is that they have a comorbid eating disorder, maybe Wellbutrin might not be the option. Maybe I'll try something else, right? Maybe an atypical antidepressant, which has a little bit of a serotonin reuptake inhibitor, but has other receptors on it, like Trintellix, vortioxetine, or vilazodone, Vibrant, which is a 5-HT1A partial agonist, as well as a serotonin reuptake inhibitor, all right? The 5-HT1A partial agonist counteracts the sexual dysfunction, so it's much less than an SSRI. See how like tailor all the meds, I know what all the receptors do. I'm matching the symptoms that the patients are telling me to each receptor. So therefore, I'm not blanketly just increasing serotonin in someone's brain and causing a whole bunch of side effects. Yes, question.
Yeah, Professor, in that tone of, for example, somebody with depression and is complaining of insomnia, and of course, that's an issue. And if an SSRI is given, it might be that it can make the insomnia, maybe it doesn't address the insomnia. So my question is, do you consider TCA, like, what's the name, Avilat? I forgot the name of the tricyclic antidepressant for that is usually given for to sleep a little bit. I think it's I forgot.
You could, but I'm going to break it down for you, the rationale as to why you prescribe certain meds, all right? This is why it's important to understand neurophysiology, because you need to understand why SSRIs are actually causing insomnia, all right? I could do a whole lecture on the sleeping disorder, which I probably will next time, but sleep is very important. So there's certain parts of our sleep cycle in which deep sleep, you need to have a certain, you actually need to have a certain amount of neurotransmitters, whether it's too much or too little, in a general sense. When you're in deep sleep, you're actually not supposed to have a lot of serotonin. When someone is in deep sleep, normally who's not on medication, their serotonin levels tend to drop actually. And when it drops down, that's when they hit deep sleep and they feel rested, right? If you increase serotonin with an SSRI, what's going to happen is you're going to keep serotonin so high the whole time during each part of the sleep cycle. So they're never going to hit deep sleep because serotonin is never going to go down, and they're going to stay in that in the light sleep area, right? They're not going to hit deep sleep. So what you want to do actually is you want to counteract what the serotonin does by giving them serotonin blockers, right? A 5-HT2A antagonist like trazodone or mirtazapine. So instead of using a tricyclic, which is a dirty drug, doesn't affect 5-HT2A, but is going to cause anticholinergic antihistamine, you're going to get them to sleep by blocking histamine. But in reality, you should know scientifically what the serotonin is doing, right? So it's increasing serotonin. How do you decrease serotonin? Blocking the serotonin receptor. So even though they might do the same thing, to be more precise, you should just give them trazodone or mirtazapine, which is a 5-HT2A antagonist. Does that make sense to you? I was trying to make it basic, but
yeah,
SSRIs do. They increase serotonin when they should be dropping during deep sleep. So you need to give someone a serotonin antagonist, more specifically trazodone, 5-HT2A antagonist, or mirtazapine, which is a 5-HT2A antagonist. You can give them antihistamine. It's going to do the same thing, but in reality, it's like a messy way. It's like killing a fly with a hammer. Sure, you can kill a fly with a hammer. You can kill it with a newspaper. It's going to do the same thing, but why use a hammer if you can use a newspaper? Sorry, I went on a tangent here, but I'm just exposing you guys to how complicated and how intricate psychopharmacology could be and how you guys should practice, all right? Aim to practice the way I'm practicing. Be very precise, know how the neurotransmitters work, understand the pharmacokinetics, understand the pharmacodynamics, and you can thank me later on as you guys progress and become nurse practitioners, all right? Any other questions? Okay. All right, well, reach out to me if you have any other questions. I'm going to reach out to Professor Smith and ask about the midterm. That seems to be the #1 question today. And if you have any other questions, let me know. If not, I'll see you tomorrow for the lithium lecture. All right? Take care. Thank you, everyone. Bye.
Thank you.